First, we start with that non-invasive mechanical ventilation in ARDS. Non-invasive respiratory support in ARDS. What are the advantages of non-invasive respiratory support in ARDS? Obviously, if you are avoiding the intubation, which means that there is intubation related complication will be less. There is intubation related complications. Most commonly, there is a very unavoidable complication in ICU is that infection. So, the ventilator associated pneumonia is less common with non-invasive respiratory support. If you put on patient on ventilator, you have to give sedations, especially some of the severe ARDS, you have to give muscle relaxant or sedation. All these sedations or prolonged mechanical ventilation, it's going to increase the muscle weakness. So, if you have put on the patient on non-invasive mechanical ventilation with less sedation, the weakness also will be the critical illness neuromyopathy also will be less with patients with non-invasive respiratory support in ARDS. What are the disadvantages? I already told the main aim of the mechanical delivery of mechanical ventilation in ARDS to maintain a safest level of gas exchange. It's not to not try to completely correct the abnormality in the gas exchange. That means that you should not try to keep a PCO2 of 35 to 45. It doesn't. If you want to keep that 35 to 45 in severe ARDS, you have to deliver a high tidal volume, a high rate. It's not possible. It won't be appropriate in the patient with severe ARDS. So our main aim is to maintain a gas exchange in the safest level and deliver a productive mechanical ventilations. To deliver a safest level of mechanical ventilation to ARDS, the main aim is to low level of tidal volume. That is a proven benefit in ARDS. If the patient on non-invasive support, the patient can take a deep negative spin. The delivery of the tidal volume will change. We cannot control a tidal volume. It's very difficult to control a tidal volume in a non-invasive respiratory support. There is a risk of high tidal volume. If it is high tidal volume, the valve trauma will increase. So, it depends upon the patient respiratory drive. Second thing is that the limit applicable PEEP. For example, the non-invasive mechanical ventilation, especially the patients who are delivering a non-invasive support through the NIV mask, you can deliver a PEEP of 10. If you are increasing the PEEP more than 10, the leak will increase. It cannot deliver to the patient. The leak will increase. The positive pressure won't reach the lung. The patient won't tolerate that. For example, you cannot patient with severe ARDS with PF ratio of 60, you cannot deliver the requirement of PEEP through the non-invasive mechanical ventilation. These are the disadvantages of non-invasive support in ARDS. What are the options of non-invasive respiratory support available for the patients with ARDS? First is our routine mask, face mask and venturi mask. In those settings, you won't apply PEEP. Just you supplement the oxygen. The patient has to initiate and deliver the breath. Initiate the breath and all will be determined by the patient except FiO2. The second thing is that CPAP. CPAP means you only deliver a positive end expiratory pressure. If you want to deliver a CPAP in ICU ventilator, you just set a PEEP and FiO2. The patient will determine that what level of how much tidal volume they want to take, all determined by the patient. Just you will set a PEEP. Example, I set up CPAP, I set a PEEP of 8. My patient will take breath at the level of PEEP. For example, I set a PEEP that is in the face mask, there is no PEEP. The patient will take breaths and inspiration expiration at the 0 PEEP. That inspiration expiration, the pressure will be 0. If it is I applied the external PEEP through the CPAP of 8, the patient will take up initiation and inspiration expiration at the PEEP of 8. So, if it is next is the bi-level, it's a BiPAP support. In the PEEP additional, I will set a pressure support of 5. So, this is a pressure support will be delivered. It's a BiPAP. The spontaneous means patient will work on the 0 PEEP. CPAP means the patient will take a breath at the PEEP of 8. BiPAP means I will deliver a PEEP. That is the constant pressure it will be occur in the lung with the both inspiration and expiration. On top of that, I will deliver a positive breath. Example, PSP I set as a 5 means that ventilator will deliver a 5 centimeter water positive pressure on top of the PEEP during the inspiration. It's a BiPAP. Other important non-invasive respiratory support in ARDS is the high flow nasal cannula. In this, we won't set a normally in the high flow nasal cannula, I will set a 3 things. One is a flow, FiO2 and the temperature. Because of the high flow with better humidity, we can deliver the high FiO2 with a high flow nasal cannula compared to the other oxygen delivering devices like venturi mask. The maximum we can deliver 60%. Here in the high flow nasal cannula, we can deliver the 100% at the high flow rate around 60 liter with good humidity file. What are the advantages of high flow nasal cannula compared to the other oxygen delivering devices? Because of this high flow, it decreases the dead space in the patient's airway. So, it decreases the minute ventilation, it decreases the respiratory rate, and respiratory drive also it will decrease. That is one advantage. The second thing is that it can deliver a high FiO2. Because of the certain high flow, there will be some PEEP will be occurs. For example, in the spontaneous breath, the PEEP is 0. If I get a high flow nasal cannula at 60 liter, FiO2 of 40%, my patient's mouth is closed, which means that it will deliver at least 4 to 5 centimeter of PEEP. So, some of the additional PEEP will be delivered with the high flow nasal cannula. There is a 4 options are available. One is a normal mask, second is a CPAP, third is a BiPAP, which means that associated with the PEEP, you will deliver a pressure support breath during inspiration. The fourth one is the high flow nasal cannula.